Welcome to the Ambulance Transport Indicators webinar. This webinar is designed for ambulance companies that are billing Medicare and whether or not to answer the question whether or not they should use a transport indicator. I'm Tom Ryan with Provider Outreach and Education, your host and presenter today. We also have Leanne Foster joining. She is going to be the technical support, so the one answering those questions in chat, making sure you get everything you need down there. Also have a clinical staff on just in case a clinical question comes up. Sometimes some of those terms are not within my wheelhouse, so we wanted to make sure that one of the clinical staff attended. She may or may not be on the entire time. It will just depend on her schedule and what allows for that. So again, welcome to the Ambulance Transport Indicators webinar. I want to run through a little bit of information with you guys on some legal stuff. So let's start here. This education was current of the day that it was prepared and is current as of today. So I verified the information. However, anyone who deals with Medicare knows that Medicare changes frequently. So please be aware that if it does change anything on the CMS website or the official regulations will override this education. So please be aware of that and continue to follow through with that information. I did receive a variety of pre-submitted questions. I will do my best to answer those questions. However, I can only answer those questions based on the information you give me. So if you are leaving out something and I'm not sure, I may answer the question as best I can. So please be as clear as you can. If I do not clarify something or you don't know what I'm talking about, or I asked for clarity, please put it into the chat. If not, you'll need to do a follow-up email to get me that information because I can only give you the question and the answer based on what I have. Okay. Last item, just FYI for you, CMS does prohibit the recording, screenshot, or anything of this presentation for profit-making purposes. Because we're not sure that you won't use it for profit-making purposes and how you will use it, we ask that you simply don't record this at all. On the other hand, what we will do is record it, put it onto our YouTube channel as an encore, link it onto our website, and you'll be able to grab it from there. I asked Leanne to put a link to the encore playlist in the chat, so she probably did that already, but if you're not aware of that, it's there. Later on, if time permits, I will show you where to find that because we did have a couple of questions come in about where that's located. So what will we cover today and what is the goal of this particular webinar? Today we're going to cover transport indicators. We're going to define them. We're going to actually explain what the transport indicators are and give you some usage tips. Last, we're going to talk about some information on where to locate these on the claim. This particular webinar is designed to help you understand the transport indicators, the use of the transport indicators, but also that CMS doesn't require them. Did everyone catch that? Because that was the first submitted question and it was quite often submitted. Is this a required item on a claim? And the answer is no, but it is something you can add to a claim. And we'll talk more about why that might be your decision. But again, there's some basic things that we have to go through as well. So that basic stuff starts with some of these definitions. And the first definition that we had a question come in is regarding emergency medical technicians and how Medicare uses that. Now, this question was based in the fact that when we look at this information, the way that your state authorizes it does not list the paramedic as an emergency medical technician, but Medicare does. So I want to go over this just to make it as clear as possible during this course as to what I'm talking about. Okay, so CMS defines an emergency medical technician as anyone who is state or local authority recognizes their licensure as being an EMT basic, EMTB, EMT intermediate, EMTI, and EMT paramedic or EMTP. Notice they all start with EMT. The other part of this is, does the term intermediate need to be there? No, it's a licensure level. So intermediate level simply means you're not the basic, but you're not a paramedic. You're kind of in the middle, and that's a recognized license by CMS. So when I use these different terms, I'm actually talking about the CMS requirement, not necessarily your state licensure requirements. Your state licensure requirements may use different terminology. The three basic levels, lowest being basic, intermediate being the middle, and paramedic being the highest. But for CMS purposes, they are all considered an EMT, so long as they're legally authorized to operate all life-saving and life-sustaining equipment. That can be done at a state level, but it can also be done at a local level because some local areas within our jurisdictions do have different established criteria. So why is all of this important? Well, one of the things that you're going to hear me talk about is an assessment, an EMT assessment. And it's what Medicare uses to establish medically necessary. What that means is the service must be medically necessary for Medicare to even consider the run. So the service has to establish medical necessity. Well, who within that service does that? It's the actual EMT assessing the patient when they see the patient. So you can use a lot of other information, but the assessment itself is what establishes that. Without that, you don't even need to worry about billing Medicare if you don't want to. You can bill Medicare, but it's a non-covered service, non-covered. So let's move on and talk just a little bit more about that medical necessity. So medical necessity incorporates the EMT assessment. During the assessment, the EMT must establish that the ambulance is the only safe method of transportation. It doesn't mean that it is the only available method. And I want you guys to highlight safe method, not necessarily available method, okay? Now, this does mean that it could be the only safe method due to monitoring, active treatment, or due to harm of self or others. A lot of times harm ourselves or others is what the mental health category falls into, but you must establish that and the immediate need for it. When we look at this medical necessity, what we're looking for is why is that EMT, it doesn't matter which level, one of the three levels, why are they at that level? So the assessment requires that this be done at a middle level, intermediate level, but the service actually is going to only require an EMT basic. That intermediate, because the assessment needed it, would be billable at that level. You want to make sure that you're aware of that because there's a transport indicator to indicate that. So lots of different things going back and forth, but start with your documentation. Start with the assessment and make sure it's medically necessary. In most cases, this is the finding coming from medical review. It's not medically necessary. Doesn't matter even about anything else because we don't go any further. We got through the basics of it, but then, oh, it wasn't medically necessary. The assessment doesn't support that. However, keep in mind when you're talking about ambulance indicators, while they are not required, they can help us as your Medicare administrative contractor or MAC who processes your claims understand the need for it. And that's the goal of them because you cannot always diagnose a patient. Now I say always, you can never diagnose as an EMT. However, could you be given a diagnosis from a hospital or a skilled nursing facility for why this transport is needed? The answer is yes. This does not override an assessment though. Just because a patient has a certain diagnosis does not mean they automatically get transports. What we want to look for is again that EMT assessment to establish the medical necessity, which is also what a transport indicator will help us understand. Okay, so you want to make sure you're well aware of that. Now, when we talk about transport indicators, there are three categories. One is that could be used for all types of transports, and then we have ones that are only for ground and ones that are only for air. So I want to define for you what that is. One of the questions that I received was a confusion over the ground versus air indicators. Oops, so let's start with the ground. Start with the ground. A ground transport occurs when it is a vehicle that is driven by someone who's state licensed and by someone who meets the EMT requirement at any of the levels. The EMT requirement is the one who's treating the patient and doing the assessment. Medicare doesn't necessarily say an EMT has to be the driver. They do say you should probably have a state license for that though, right? I mean, that's the basics there. That's a state driver's license, very different. The person treating them, doing the assessment must do that portion of the assessment and must treat medical necessity. They must establish all of that. The ground rig must have your basic information, must have your basic supplies and items needed to treat the patient's medical condition today. That's key. Without that, then you can't move to the next level of ground transport, whether that's an ALS or anything like that, okay? Now there's certain requirements that go with this because EMTB can do an assessment, right? Basics can do assessments, but they can only do the basic level. And EMTI, which is that intermediate level, now they could do assessments. They could show, oh, well, the patient only really needed an EMT basic. They could also do an assessment for an EMT basic because that's all the condition required. They could also do an assessment saying, yeah, We get it. They need an intermediate level or an advanced life support level. Okay. The paramedic, though, is the one that would need to assess for a specialty care transport. Now, the paramedic could also go with another medical personnel. So, for instance, if there's a nurse on board who's that, or if there's a respiratory therapist and the patient's condition relates to that, if they're going to be on board, they can use that type of an assessment as well. It doesn't necessarily need to be by the EMT for a specialty care transport, but that's the highest level. So we just want to make sure that everyone is well aware that, yes, we know this assessment has to occur, but this definitely affects the medical necessity and the reimbursement levels. And so when you're looking at your transport indicators and you're trying to determine which one to use, you want to be aware of these levels, and as well as what is ground versus air. I threw this one in. It wasn't based on the question, but just to give everyone a little heads up, air transports are divided into two, fixed wing and rotary. So airplane versus helicopter. They do both have to be medically necessary. They do both have a time component. Would it have been easier or less time to transport someone by ground? So we see this a lot of times with fixed wing. So what we're looking for is what makes it medically necessary for them to need that air transport, especially if it's going to take less time. If the ground rig would have picked them up, moved them to the other facility in case of a higher level of care, or we could have gotten the person there due to a car accident and the ground could have safely taken them, but instead we called in one of the other items. So just be aware that we do cover air transport, but there is a couple of additional requirements that would go into that assessment and that would go into that medical necessity portion before we get too far into the indicators and the stuff that goes in with those. All right, let's move on a little bit more. Keep going with some definitions and stuff. So medical conditions, these are the transport reasons documented by the EMT. Someone asked me very specifically, an EMT is not in their area allowed to diagnose. This is very common. Most EMTs are not allowed to diagnose by licensure. However, a claim requires a diagnosis code. So what do they do? Well, that's what your transport indicators are designed to help with, but also you still need a diagnosis code. So what you're going to do is put the patient complaint there. Could you use a documented sign and symptoms? Sure, whatever that documented sign and symptom is. So patients complaining about dizziness, documented sign and symptom is that as they stand up, their balance is off, their gait is off. Those are signs and symptoms. So you want to make sure you document all of that. And those can be what you base your diagnosis on. That's why Medicare doesn't necessarily consider the diagnosis alone. The last one on this one is to let you know that, yes, it is okay for you to use a doctor or non-physician practitioner's diagnosis code. While this is what's best, it still doesn't drive medical necessity for a claim. Again, only an assessment can do that. So we will give you that, we will assume that a service is necessary unless it's medically reviewed. We don't necessarily require every single claim that comes in to go through this. So when we look at these medical conditions and we're looking at the condition code list, that's what we're going to talk about today. How else can we help support the diagnosis code? And we'll talk more about that. Okay. The next question was pretty basic. So I built this slide in to answer that. And it was, what's this condition indicator? What is it? So it's defined as a 2-character code that identifies the necessity for transport in a certain way or in certain circumstances. So 2 characters. This will help then support the medical conditions that we talked about previously. So it's a code used to add additional information to the claim. That's why it's not mandatory. That's why it's optional, because it adds additional support. However, it still does need to be supported in the medical record. The run report could be the dispatch report, somewhere that you looked at this. Now I say dispatch report in that it can give you some basic information for why this type of an ambulance was dispatched air versus ground. However, it does not support what will happen with the patient, and it does not replace the assessment by the EMT. So when you're looking at the medical indicators and when we're talking about the ambulance indicators in particular, remember the EMT assessment is a big part of what we'll use to determine if it's right or wrong. Now, one of the other questions that was asked of me is, there's one that, oops, sorry, I went too far. There is one that actually mentions the the Emergency Medical Treatment and Labor Act, or EMTALA. This is a hospital emergency department providing medical screening. And what does that mean? Well, this does not mean that that hospital may be qualified. It's not what it says to treat the patient. It says we're going to screen them to determine whether or not this patient needs treatment and if they are qualified. There's a whole set of regulations that we're not going to necessarily get into all of that, but I did want to make sure that you are aware that it is there. We do want to look at it and we will talk more about it. Now, when you get into this regulation and you're trying to get a summary of it without getting into all the detail, because if you want the detail, consult a legal person, lawyer, someone like that who can help you through that, your legal counsel. On the other hand, CMS does provide a really handy sheet, and it's just going to be provided for you on this slide. And what this is when you click on it, it will open up a PDF document. And what it's going to do is just run you through the basics of this information. And it didn't work. Why did the link not work? Let's try this again. See if I can put it this way. Okay, so the link that is in the chat works fine, which is actually the same link on the slide. Don't know why it's doing that. But so you can see it just runs you through some basic information. It'll give you some guidelines. Down here is the EMTALA Know Your Rights and the information you need. I don't know why that link did not work from the PowerPoint. So if you are available, grab it from the chat. If you want it, go ahead and email me and we'll get that out to you. So under this information, there are 4 requirements that you need to be aware of. Let's explain these. The patient with an emergency medical condition may only be transferred after screening. Again, did you catch that? After screening. The provision of stabilizing treatment. So this means you screen, you stabilize, now you determine whether or not you are the right facility to treat them on a long-term basis or to treat that illness or injury. That's what EMTALA is trying to do. The transferring hospital minimizes the medical risk. Key number 1, you have to minimize the medical risk. Again, that kind of goes with stabilizing the patient, right? Making sure they're ready to be. 2, the receiving medical facility has the space available and qualified personnel available for treatment and agrees to accept the transfer. You can't just send them away. You have to make sure that they're ready, that facility is aware they're coming. The transferring hospital sends all medical records related to the emergency condition that are available at the time of transport and any other records not yet available as soon as practicable. In other words, when you send the patient with the EMT, you may be asking them to carry medical records as well. Now, these records may be helpful to the EMT as well, so they may ask for a double copy of it. 1, because it's going to help them treat the patient. 2, it's going to help prove the medical necessity for the transport. I said help prove, not prove alone. Remember, the only thing that can prove the medical necessity is that assessment today. The last criteria, the patient is transferred using the appropriate personnel and transportation, including the use of necessary medically appropriate life-saving measures during the transfer. This means that you transfer by ground if you can, but air if you can't. So other than that, if it's not that type of a transport and you don't need an ambulance at all, the question was regarding a wheelchair van. If the patient could safely go by a wheelchair van, Medicare will not consider that transport. Understood you got them stable, understood everything is going on, and now they're fine enough to go by a wheelchair van. There's no medical necessity to support that. This should not be then billed as a medically necessary ambulance transport, even if the ambulance is transporting them. It could be billed as an ambulance transport, but we want to make sure we incorporate the GY modifier or the condition code to say it's a non-covered service. Okay. So hopefully that gives you a little bit or enough information about that particular set of laws, the EMTALA. And if you have more, just put some more questions in chat for me. The next questions that came up are the actual indicators and which ones are air, which ones are ground, and which ones are air and ground. So let's go ahead and take a look at that information next. I chose universal indicators, and these are air and ground, and any ambulance transport can use these. I'll talk more about where they go in the bill in just a little while. But the basic first one starts off with a higher level of transport is needed based on EMTALA regulations and guidelines. In other words, this patient can't be treated at this facility. We don't have the care available. So we want to make sure we're getting them where they're going. And this could be a one where we're bypassing certain facilities because that transport isn't to that facility necessarily. They can't treat them either. So again, there we go. Interfacility transport when a required service isn't available. And I want you to note on this one, it says required service isn't available. It doesn't mean that your facility couldn't do the service in general. It means that right now, at this moment, for whatever reason, that required service isn't available. So one of the questions came in and said, we have someone that is needs to have an operation done. It's not an urgent operation, but it is something that needs to be done. And they were talking about, I believe, the fracture of a leg that needed to be repaired. Now, they wanted them transported because, yes, it should be done and we should get that done, but their OR would not be available to do it. Why wasn't their OR available? Well, first, they didn't have a surgeon. So while the room was there, the surgeon was not. So that means not available right now. So that's what we're talking about. They had the OR, they just don't have the personnel or the surgeon to do it. C3 is response to major incident or mechanism of injury. This is exactly what we're talking about. Car accidents, any of those types of incidences or mechanisms of injury. It's a very generic one used. It doesn't give us a ton of mileage, but it is something that's useful for us to understand that you're responding to a major incident or mechanism of injury. You can use your definition of major for whatever you want there. Okay, let me say that again. You can use your definition of major however you want there. Okay. C4, medically necessary transport where the billed mileage may appear excessive. So a lot of you may or may not be aware of the A0425 ground code, most commonly billed one here. Now, both air mileage could have this as well, fixed and rotary, but most common it's the A0425 for ground. What this is saying is when we look at it, we look at the nearest appropriate facility. Now, remember, nearest appropriate facility is physically, distance-wise, the nearest facility that has the bed, staff, and equipment available. We also look at locality. Where would this patient commonly go? Where would patients from this facility commonly go to be treated? Sometimes there is a reason they have to go outside of that. So I can give you an example. There's a car pileup on the interstate and there are a lot of patients that need to be treated. Well, so the common areas that they would typically go to are full because it was a car accident and it involved whatever the situation is. So we went outside of that because that was the safest. Another one in which a C4 was used, and this was a very specific question that I did want to address. Could this be used for a weather-related condition? And the answer is absolutely. So if you're trying to transport this patient and there is a weather front, for whatever that weather front happens to be, tornado, storm, thunderstorm, if you happen to live like me, tropical storm, I live in Florida. So whatever's going on, right, there's a weather front. Yes, you could use this to indicate that. What this is telling us is, hey, we had additional mileage. We know we did. You can ask for more information, but know that we are aware that there was additional mileage than where we would normally have gone. That's what the C4 will help you with. So that's why both air and ground can use those. On the other hand, there are specific ones that are for ground only. And this is one that we talked about, and this is the C5, where the patient's condition that was reported to dispatch supports the ALS, but a BLS supports the ALS, and the ALS assessment was there, except you did a BLS transport. Why would this occur? The only available person to treat them is an EMTB. Therefore, you don't have that next level up. So while we may have wanted to have that person and it would have supported the medical necessity to have that higher level, unfortunately, it's not possible today. Dispatch protocols required the ALS response, but on scene, it was determined that a BLS is payable. Is medically necessary. BLS is medically necessary. Now, this one does allow for an ALS to be billed, an ALS non-emergent or emergent, depending, at a level 1, not an ALS 2, but a level 1. And so what you're telling us is our protocol required us to send that next level up. Can't send a basic, had to send either a paramedic or an intermediate. But once they got there and they did the assessment, when you read the assessment, we understand that a basic would have been able to complete this transport. We do understand that. However, because of protocol, this is what we did. Medicare does state that that would be payable at the ALS level of care, ALS 1 level of care, not the ALS level of 2. That's always going to be an emergent. So you want to make sure you're putting that one on there. C7, it's pretty self-explanatory. This patient did require IV medication en route. So while you were taking, they had an IV, it was active, you had to monitor it, you had to keep the medication flowing, you had to check the patient's conditions, and all of the things related to that medication. That's what a C7 is used for. All right. Somebody did ask me for the information regarding the C6 and where I would locate that information. And it's actually going to be in the Medicare Benefit Policy Manual in Chapter 10, Section 1.1.1. I'll show that to you in a little while, and then we'll get you through some more information, but I just want you to have that. So the C6 information, where we're actually dispatched at that higher level, but that could have been done at the lower level, but then it can still be billed at the higher level. Did you catch all of that? It's within the Medicare Benefit Policy Manual, again, Chapter 10, Section 30.1.1. Air only are your codes that you can use for air only. And again, you want to be able to say within the medical records, within the run report, within the assessment, wherever that is at, that the air is the only safe means of transport, and here's why. One, it could be a long distance transport, right? The sheer distance to get them there, it's not safe to take them by ground. Two, there are traffic patterns which preclude the ground. So for instance, there was one situation where we got a claim in, and it was in an area where the interstate system was under construction, which would have actually added about 4 hours during rush hour for this transport. So while it looked like on a map, you could have just simply driven in there, would have been good. The traffic did not allow for it because of the construction. And during the time the transport was needed, that would be an example of when to use that. Patient's condition precludes the time to the closest appropriate hospital by ground. This one is used to say the patient themselves, not that the ground wouldn't be faster, but that the time they're in that rig, that actual transport, is what precludes the use of ground. What we're looking at here is why should you put them into a fixed or a rotary when we could have transported them, but their condition is so severe that you can't treat them that way, and it's unsafe to actually treat them that way. Also, the last one, pretty self-explanatory. You can't get to them except for by air. Lots of times we see this in some of our rural areas, farming accidents, you know, and the UP of Michigan is an example where we see some of this stuff. There's just not possible to bring a ground rig to them. So we need to get them out of the area and safely, as quickly as possible, safely to a facility. That's what D4 is used for. Okay. All right, let's move on. What next with this one? I want to talk a little bit about the claim and where this is going to go so that you have an understanding what we're looking for. Now, remember that we do have 4 types of claims within Medicare. 2 of them are paper and 2 of them are electronic. The first slide here just does show the 2 paper claim forms. The 1500 relates to the 837P. Those are your professional transactions. They're billed to the multi-carrier system, multi-contractor system, whichever one you want to call it. It's MCS. The UB04 837I are billed to the Physical Intermediary Standard System, BIS. Ambulance transports are a Part B service, but they can be billed on both types of claims. So you want to make sure when you're writing this information down or when I go over something, you have it in the right fields. Otherwise, this can cause problems. Okay, so that's just really why I wanted to make note of that. One of the things to keep in mind is we don't always look at some of the narrative fields, which is where this information must be, narrative field, unless it stops for something else. So that means that just because you append a transport indicator, will we automatically stop to look at it? And the answer is no. Our claims processing system is not built that way. Both claims processing systems can process a claim cleanly without looking at that. On the other hand, let's say it has to stop and we're looking for additional information. We're looking for something about medical necessity. We're looking for something related to a diagnosis. Because something's not equaling right, then we would look also into the extra narrative fields or the narrative fields to make sure we have this. Okay, so hopefully that provides a little bit of a better understanding. But let's talk about those narrative fields. Remember, this indicator is solely used to help support a diagnosis code or to support a type of transport. It is not designed to replace a diagnosis code. One question that came in, do I need to have a diagnosis code on a 1500 claim form for an ambulance transport? No, you do not. The diagnosis code is required on every electronic claim, though. By the way, we receive about 95% of all of our claims electronically. It's a little bit higher for ambulance. Sometimes drops a little bit lower, so I'm using the 95% mark. So if you think about that, most of them require it. Again, if you don't know an actual diagnosis code, you don't have it from a medical professional, feel free to code the signs and symptoms. These medical condition codes, they may help. They may help with that, but they're not required. So hopefully that kind of answers that question. Because it's not required and it is not a valid diagnosis code, it must be placed in the narrative fields. So it could be placed in the appropriate line narrative field if you're doing a electronic bill. It could be placed in either one of the narrative fields on the 1500 or UB04. It depends, but it has to be in that. A lot of questions again on this. So optional use. I think I've said that a lot. Even though it's optional to use it, however, you still have to support it in the documentation. If it's not supported in the documentation, this will not be something that you should be, information that you should be using. It will actually not help pay your claim. That could cause other issues and be found as an error for Medicare and for you, which means we may take our money back, or we may ask you to fix the claim or do something else. So please make sure that if you're using it, it is properly supported within the documentation. All right. I know I gave you a lot of information. I did want to mention that I did say there was going to be a couple of resources I'm going to show you. So we're going to start with those resources before we actually delve into the question and answers. The first one that I mentioned is actually on the CMS website. Oops, well, I still have it up, but we're going to go back to CMS this way. On the CMS website, I mentioned the Medicare Benefits Policy Manual, and I said, hey, this is a good opportunity. I mentioned it in regards to the life support, the dispatch protocols for ground. So we'll take a look at that and I'll show you a little bit about that and then we'll move on from there. So the first thing we're going to do is go to cms.gov, Medicare, regulations and guidance. Once this opens and you'll see that the change on the right side, we're going to go to manuals. So it's going to be the left column. And once inside manuals, we want to go to internet only manuals. Now, this is our day-to-day operating instructions. They're called the internet-only manuals. Each manual has a title publication number. In this case, I said it was the Medicare Benefit Policy Manual. So again, what are we looking for? That we can pay an ALS transport level when only a BLS transport was required, so long as an ALS assessment was required. So it's going to be in the benefit area. Click on 100-02 because that's the publication number. We're going to scroll down. In particular, we want to go to Chapter 10. Now, somebody asked me, do I get to ignore the rest of this information? Absolutely not. Depending on how you bill and have to bill on paper for any reason, there are actual information within there that you would want to look. It's just not within the benefit manual, right? Or if you want to scroll down, you can find out general exclusions of coverage and all those kinds of things. So let's go to Chapter 10 for this particular section. Once inside Chapter 10, you can read through all kinds of stuff, right? It's going to talk about medical necessity. It's going to talk about our destinations, all of that type of thing. Now, while it does talk about the destination here, it doesn't talk about coding the destination. And that's another question that we did have, and I'll address that in just a moment. On the other hand, I'm just going to scroll down for a moment, and we're going to come to 30, and we're going to come to 30.1. Point 1, ground ambulance. Once we open that up, it will talk about the advanced life support and the assessments, and then how all of that plays together, and how if you do an advanced life support assessment, it is a payable service. So hopefully that makes sense. And it's right here, including the provision of an ALS assessment by an ALS personnel or at least one ALS intervention. This makes it an ALS 1. Okay. So that's where that came from, and that was a very specific question, so I definitely wanted to address that. The next one is actually, I'm going to step back for a moment here The next one we're going to go to is in the Medicare Claims Processing Manual. This one's a little bit different. Now, this is our day-to-day operating instructions for what happens within the system. So the benefits talk about what's payable, what's not, that type of thing. This one is claims processing. Inside claims processing, we're going to scroll down. We're going to go to the ambulance chapter, which is chapter 15. For those of you that are like, I don't know this stuff off the top of my head, I do understand that. And in chapter 15, the question that we're trying to answer with this lookup, what is the modifiers? What are the destinations that Medicare will cover? So if we read through, we can read through a bunch of stuff, but then we're like, I don't really know. So I'm just going to go ahead and go to the general billing guidelines. Now, keep in mind, this is for both A and for systems, right? So the multi-carrier system and the physical intermediary. Now, I just happen to know where this is. You could search the term modifier. You could also search for any type of information you want like that. That's fine. I'm just going to go to the general billing guidelines. Once I open this up, A, which is right here, talks about the modifiers. Now, these are what need to be appended to a claim to represent a destination or an origin. There are certain modifiers that say this is a destination or this is an origin code only. Okay. So for instance, a physician's office looks very similar to an intermediate stop at a physician's office. Hey, they're the same, right? Not at all. The X is a destination code. It should never be used as an origin, and it is payable because it is on the way to a hospital. This was not your intended stop. The P is never payable destination. Okay, Medicare does not cover to a physician's office. So when you're looking down this list, you're going to make it work the best you can for any origin. You just have to make it work. However, for destinations, it has to be specifically listed here. So the question that came in is, how do I locate a list of non-covered Medicare destinations? And the answer is, first of all, start with what is covered and everything else is not covered. That's how CMS says it. Start with what is covered, but everything else is not covered. I'm going to give you an example. Do you see freestanding emergency room on here? And the answer is nope, there's no freestanding emergency room. That's not what it is. So therefore, Medicare does not cover that. On the other hand, do you see hospital? Sure, that's right here. That's an H. A hospital can be a covered destination, as well as a hospital-owned off-campus emergency room that is freestanding. Why? Because it's still part of the hospital, it's just off campus. And that's also then defined as 250 feet or more, and that's also in this area here. So that's how we look at this. I did have a question before I leave this section on, I'm sorry, it's E, okay, which is resident domiciliary custodial care versus SNF, skilled nursing facility, or N. And the question was, we're leaving an E, we're going to a hospital, or we're leaving an N and going to a hospital. How do I know which one it is? And this is based on the patient's condition and whether or not the patient lives there. If it's a non-medically necessary stay, or Medicare is no longer paying on that. In other words, 100 days Medicare isn't paying, then it's an E. Medicare is not paying for the room and board. If Medicare is paying for the room and board, which means it's medically necessary and within the first 100 days, then it's an N. So hopefully that answers your question. Now that does not affect the actual transport indicator codes. None of that is affected here. So just be aware of that. So I answered a lot of questions very quickly. If you need more clarification, please let me know. Another one that came onto this is, when will Medicare allow us to transport from a home to a doctor's appointment? Okay, so let's talk about that. The home is a covered origin and destination. It's called residence. We're good. And we doesn't say the patient's residence, because it doesn't necessarily have to be the patient. It could just be a private residence, their child or whatever. On the other hand, the physician's office, and we just talked about this, Medicare does not cover this as a destination. Doesn't do it. Therefore, it's never going to be a covered service. Medicare's saying, hey, if you have to go to a physician's office, why aren't you taking a wheelchair van? Why aren't you taking some other form of transportation? And if it's that urgent, that emergent, why are you going to the physician's office? Again, with the exception of the emergency stop along the way, the intermediate stop. So that's why an X is covered, but a P is not. Again, if you have more on that, please put that back into the chat and I will answer that as I can. There was something that came in and they just literally said various qualifications for different EMS transports. Can't help you with this one. I'm not really sure what you're looking for qualifications. I'm not really sure where you were trying to go with that. So if you could put a bit more into that, that would be great. Next question, are transports indicators required? Again, this was the one that we talked about quite a bit. They're not required. They're also not allowed in the diagnosis code fields, but they're not required. They should be in the information only or the narrative fields. They will help us understand what's going on with the patient. So if you say, I just don't want to deal with these ever, that's okay too, right? I mean, that's your decision. It's up to you to decide how to best utilize them. But if you're going to utilize them, please make sure that they are supported within the medical records and that you are using them in the appropriate places. The next question says, do NICU transports in an ambulance with an incubator count as an SCT? This is a little bit different to address here. First thing I want to remind everyone, no transport automatically counts as a specialty care transport or as an advanced care life support or as a basic life support. All transports must be supported as medically necessary. So we go back to that basics, start way back. How do you prove medical necessity, whether it's NICU, whether it's an incubator, whatever the situation is? First, yes, you can consider whatever information is given to you from a facility. I'm going to guess if your patient, infant in this case, is in an incubator, you're probably not picking them up at someone's house. Now, I can't say that for sure. I'm going to say probably not. Once you've established that, can you use the information given to you by whoever? Sure, it could be a nurse, it could be a physician, it could be a physician's assistant, so it could be a variety of non-physician practitioners. What information do you know? You must, though, still provide an assessment. The assessment must be done by the EMT. Now, again, it doesn't have to be a basic, intermediate, or paramedic. That's not what it's being said. But I will tell you that if you're trying to build a specialty care transport, you need to have a really high level of assessment, which means a paramedic or someone else qualified to do that. Otherwise, you will not make that level, because if an intermediate does it, that's not going to qualify as a specialty care transport. So again, when we're looking at ground, we have to establish all of those components. The next one is one that was asked, and I think they were looking for a code that would help them. I just don't think it's possible. But how do you bill multiple trips on the same day without them denying as duplicate? For ambulance transports, there is no modifier and there is no condition code. There's nothing that's going to support that. You can try, but CMS has said if there are multiple trips on the same day, as a Fraud and Abuse Prevention Act, what they would like us to do is to review these claims. Okay, we then have to decide how to medically review them. Now, medical review means, hey, someone's got to look at it, someone's got to determine it. What they did is a magic formula. Please don't ask me to fill that in any further than that, because it takes into account the amount of man hours spent, the dollars and cents spent, and a variety of other factors on whether or not it should be pre-reviewed before we make a determination to deny it, whether or not it should be post-reviewed, so that therefore it's already denied and then you're asking for an appeal. The decision was made to do it through the appeals process, so that's why it is done that way. But we don't have any modifiers, or we don't have anything that you can append to the claim to automatically avoid that type of a denial. It doesn't exist. So there's no transport indicator. There's nothing that will help you with that. All right. Why does a claim deny for SNF inpatient CO109 when it is excluded service from consolidated billing? I'm going to say this is my last question, so if you have questions, please put those into the chat. I'll check with Leanne in just a moment. With that said, SNF consolidated billing in an ambulance is not as easy to figure out as a lot of people seem to think. Now you say, hey, I dealt with it. I understand where Tom's coming from here, right? There's a whole set of rules that go with it, and there's two different portions. One of the sets of rules says, hey, if it's a Part B, which means if the patient is not in a Medicare covered stay. What's that mean? They could be in a facility, but Medicare is not paying for the stay anymore. then that would be considered a Part B service. On the other hand, if it is a Medicare covered stay, now we have to look at whether or not this is even separately billable to Medicare or should it be billed to the SNP. That is where we come into different things. And there's a variety of factors like, hey, did the SNF bill their claim to tell us that they're no longer in a covered stay? Are they discharged and was that billed? If not, it could automatically bundle it, which is what the CO 109 stands for, billed the skilled nursing facility. So a lot of that goes back and forth. I do want to give you a resource, so bear with me as I get to this resource. First, it is on the CMS website. When you go way up to the top, we are talking about coding and billing. And when we talk about coding and billing, we're looking at skilled nursing facility consolidated billing. That's the specific question we were asked about. Right side, second item down, skilled nursing facility consolidated billing. Inside here, you have a variety of sets of files. You have a Part B file on the top and a Part A file on the bottom. Hopefully everyone is seeing this on the left side. Just because this is a Part B service does not mean that you should automatically go to the Part B file. Remember, we talked about the patient status. So is this skilled nursing facility billing for them? Then if they are, you have to determine what the service is and whether or not your service is related to that. There's a whole class on that that I taught on that that'll help you through that process. So there's a lot more that goes into it, but I want to just at least show you these basic files and help you get to some basic stuff. All right, that was my last question. I got you some basic information there, but let's move on and see if we have any questions in the chat feature.
Tom, we do have one. The question is, what determines if an ambulance claim is billed on a UB04? Is it who owns the ambulance service, for instance, a hospital?
Oh, that's a great question, and absolutely, you're dead on. So what determines that factor is who owns the ambulance and how they choose to bill. So an ambulance can bill as an independent entity, which would mean that they enrolled on the 855B application or in PICOS as a business or an organization. That would then allow them to bill on the 1500 claim form. Okay. Also 837Ps. On the other hand, if they are a part of a hospital, owned and operated by a hospital, then they're considered a piece of that hospital. They would then need to enroll on an 855A or PICOS equivalent. It's the same system, it's just how they go to enroll it. If they do that, and then they would bill on the UB04. So they would follow the UB04 billing guidelines versus the 1500 billing guidelines. So it's really dependent upon how they are owned and operated. Keep in mind on the UB04, they still must designate how they are owned and operated. And there's two different modifiers they can consider, but that's a separate billing class. And we do have that. So hopefully I got the answer good enough. If not, throw it back in chat. I'll provide more clarification. In the meantime, any other questions?
There are no other questions in the chat, Tom.
Perfect. Let's go ahead and move on then. Next thing I want to make you aware of is that there is a provider enrollment conference coming up. This is for all providers of all specialties, which would include ambulance. I would encourage you to take a look at this. It is a free conference, but it is in person. So you'd have to travel to San Diego, California in August. So this might be something you're not interested in. I'm not sure. But if you are, take an opportunity, look at it, see what's going on. This is hosted by CMS and Meridian. They're the ones that are actually hosting this annual conference. Great opportunity to hear about provider enrollment and the questions that come specifically with that. Next, there's also a provider compliance conference, two different conferences. The compliance conference is an online conference, a little bit different than the enrollment conference, enrollment in person, compliance online. This is a 2 different day conference from 12 to 4 Eastern time, and you can register and check out the agenda if you're interested in attending the compliance conference. Again, 2 different things there for you. Mian, can you check and see if we have any questions submitted in the chat?
Tom, there are no more questions in the chat.
All right, well, let's go ahead and close out then. I want to thank everybody for listening today. We encourage you to provide feedback on the survey. Remember, I want my good, my bad, and my ugly. So what did I do well? What could I have done better? But also, was my PowerPoint nice? Did you like it? Were there things I could have done better within the PowerPoint? Any of that type of information. The good, the bad, and the ugly. Always include topics that you'd like us to see. Please be specific. Don't just say ambulance. I don't know what you want if you're just saying ambulance. Remember to take the time to review our live events page to register for future education. It is the first place we review those. We typically post our new upcoming events on Mondays and Fridays, only once a week. But don't forget to view that Encore playlist as well, because that's where we're going to find different things like this. So on behalf of myself, Leanne, all of Provider Action Education, I'd like to thank you for attending and participating today. We really look forward to your survey comments, and we hope that you'll join us again in the future. Thanks, everybody. You may now disconnect.